Bismillah ar-Rahman ar-Rahim. Good morning, good afternoon, and good evening, my dear vascular colleague. I would like to speak today about the ESVS guidelines 2023 antithrombotic, which I'm sure we'll be using over the next couple of years. My name is Dr. Muhammad Omar Farouk. I'm a consultant vascular surgeon. The ES 2023 has been issued in April. And it's a very nice document, 69 pages, extremely interesting to read, but I have tried to put the absolute summary, which is the minimum amount of information for you to be able to have. If you want to get download to the document, you can just scan this QR code, and I will summarize the second part of the ESVS antithrombotic treatment guidelines. In the second part, we'll speak about 4 topics. 3 are very simple: vertebral, artery, atherosclerotic disease, upper limb, renal and mesenteric, and I will focus on the lower limb arteries because there is a changes, not a lot of it changes, but there is a changes in the lower extremity arteries antithrombotic management. Well, if we speak about vertebral artery, it is same as carotid, but they obviously mentioned that there is no enough sufficient data to get a recommendation. So if you have a vertebral artery disease, you can use single antiplatelets, same as in carotid artery disease, but there is no recommendation for double antiplatelet therapy. If you go to the upper limb arterial disease, recommendation number 19, a patient with chronic symptomatic upper limb disease should be considered for a single antiplatelet therapy for secondary prevention of cardiovascular disease. So if you get atherosclerotic axillary artery, brachial artery, if you have seen it, then you get a single antiplatelet therapy. Same as vertebral. So vertebral, upper limb are the same. What about the renal and mesenteric? There is one recommendation number 21. Patient with asymptomatic or symptomatic more than 50% atherosclerotic renal mesenteric artery disease. So even if you've seen it on just a CT scan while patient is asymptomatic, should be considered for single antiplatelet therapy for secondary prevention of cardiovascular disease. So if you notice, both upper limb, both vertebral, renal and mesenteric, all of them are single antiplatelet therapy. Easy to remember and very important recommendation. Now let us go to the lower limb arterial disease. They have classified into asymptomatic lower limb extremity or chronic symptomatic lower limb arterial disease, or acute on top of chronic, which we have seen a lot, and perioperative antithrombotic for lower extremity intervention, and a high-risk chronic lower limb arterial disease population. Now, before I discuss what is the recommendation, I would advise you to have paper and pen and write yourself what you do in your outpatient clinic if you get someone who is symptomatic for lower limb arterial disease. Patient with previous amputation. Patient with high risk, come to the clinic. Second, put what do you do if you book a patient for FemPop or femdistal bypass? What is your antithrombotic regimen before the operation, during the operation, and after the operation? And do the same for endolist, because definitely every day you use these guidelines. And if you get the guidelines as an answer to a question, then you will memorize it better than if I just give the information. So stop the video, have maybe 1 minute, try to write down what do you do for these 3 categories. If you see lower limb arterial disease in the clinic, if you see it for operating list, the vascular operating list, or if you have seen it as an endo list. Write what you have done, think about it, and let us go ahead. So Number one, if you are asymptomatic, this is very important. Recommendation 23, asymptomatic isolated lower extremity arterial disease are not recommended to have aspirin for cardiovascular prevention. So if the patient is asymptomatic, you've seen it for any other reason, or you've seen a duplex scan, he is not complaining of anything, there is no indication even for giving anti-platelet at all. The class of recommendation is 3. The level of evidence is 8. So this is very strong evidence. So do not give lower limb arterial disease any antiplatelet or antithrombotic agent. Now let us go to the second part. If you are symptomatic, well, if you are symptomatic, instead of giving you the recommendation 24, 25, and speak about it, I will, actually the guideline, I have summarized it into very nice sheet where it summarizes all the chronic symptomatic presentation, which is either, if you see these 3 important data sheets, one for symptomatic lower extremity arterial disease, which I call it the clinic scenario, and they advise everyone to print this paper, put it on the board in your outpatient clinic. Once you use it for a couple of weeks, now you will know it by heart and you will memorize it well. The second important sheet is the one for endo. If you book a patient for iliac angioplasty, stenting, SFA, tibial or pedal, this is the sheet that you need to memorize. And if you book patient for open vascular surgery, this is the sheet that you need to memorize. So let us take them one by one in detail. So this is the first sheet with symptomatic. We said asymptomatic, you don't give anything. And this is a class A recommendation. So this is the first sheet, and let us discuss it in detail. Well, number one, we said any patient that you want to give antithrombotic treatment, number one, you do bleeding risk assessment, which we have mentioned in the previous part. They relied on bleeding risk assessment of OAC3 PAD, which is a German risk assessment score. So you do it to everyone. This is very important. This is a grade A recommendation. Now, if you get a patient with any upper GIT bleeding, peptic ulcer, then PPI or proton pump inhibitor is definitely indicated. So you'll see these two will be repeated over the next 2 sheets. Now, here we know what is new, which is from the Voyager trial and Campus trial. We know that if you added rivaroxaban 2.5 milligram twice daily plus aspirin, this is a patient who is symptomatic, you get better outcome regarding the MACE and male percentage. So here you have 2 options. Either you give single antiplatelet therapy, which is aspirin, or you give clopidogrel as a first choice if the patient is allergic to aspirin, but this is single. You can even get aspirin and low dose rivaroxaban. So they put it here as or. But the best evidence you can see is aspirin. So if you give patients just aspirin without adding rivaroxaban, you're not completely out of guidelines. But most of us are giving the second option nowadays after the Voyager results. Now, aspirin and rivaroxaban should only be used for patient not a high risk of bleeding. And this is very important. So if you have a patient with upper GIT disease or a high-risk patient who is diabetic or renal impairment, don't give this double antiplatelet therapy. Oral dual antiplatelet therapy or full dose anticoagulation are not recommended secondary cardiovascular prevention. So this is very important. If you have a patient who is symptomatic, don't anticoagulate the patient with antithrombotic agent. This is contraindicated. You just increase the bleeding risk without any benefit. Here is a recommendation color which we repeated all over. This is a class of recommendation. The green is class 1. The two color yellow, light yellow and deep yellow, 2A and 2B, and the wording that is being used should be considered and may be considered, because even the American guideline, they don't rely into this actually phrasing. So should 2A, maybe 2B. 3, don't give. So this is the very important sheet that I would like you to put in the clinic. Now, let us say that you are putting a list for an endo list for tomorrow. Now, the endo list is this sheet. I think it's a lot better for you to memorize this sheet rather than giving piece by piece guidelines. So let us say that this patient is going for iliac angioplasty. Now, again, you do bleeding risk assessment and you get PPVI if the patient is having upper GIT bleeding or history of bleeding. Now, during the procedure and after the procedure. During the procedure, intraoperative bolus of unfractionated heparin in the dose of 50 to 100 unit per kg, or lower molecular weight heparin, 0.05 milligram per kg. This is a class 2A, level evidence C. But use this one because it will dramatically drop your intraoperative occlusion. Now, again, there is very important recommendation, which is intraoperative, is to use intraoperative APTT and activated clotting time to guide your anticoagulation. This is may be used, as you can see, the dark yellow. Or you give bolus of Angiomax, which is active principal beverladine, 0.075 milligram per kg, especially if heparin is contraindicated. So if you have a patient with heparin-induced thrombocytopenia, for example, you don't want to use heparin, you can use Angiomax instead. And this is 2B. Now, post the procedure, after the procedure, then you give aspirin 75 to 100 milligram once daily, plus rivaroxaban 25 milligram, which is the same as the outpatient clinic scenario. What is in red here, do not add clopidogrel to aspirin and rivaroxaban for more than 30 days, only in exceptional circumstances, because here you will hit bleeding risk. Now, post-procedure dual antiplatelet therapy, aspirin, clopidogrel, for no more than 6 months. And this is class 2B, level of evidence C. Again, patient with pre-existing indication for full dose anticoagulation, no more than 3 months additional single antiplatelet therapy in exceptional circumstances. So this sheet, I think, is extremely important. Please print it and keep it with you, or have a copy of this image, put it on your mobile to see it frequently when you are booking a case of endo. Same with open. And all this sheet, I will put it on the Vascular Online Training community tab, where you can find all the nice summary, which I think is very helpful to summarize the information. Now, let us go to the last one. If you book a patient for FemPop bypass or FemDistal bypass, the first two are the same. I will not repeat them again. Now, during the procedure, again, use the intraoperative bolus of heparin, 50 to 100 unit per kg. This is class 2A level evidence C. And to use APTT and activated thromboplastin time to monitor your anticoagulation, which is same like the open. Now, after the procedure, if you have low risk of bleeding or high risk of bleeding, low risk of bleeding, you divide into, you are using just a vein or prosthetic. And here the regimen is aspirin, the 7 to 100, which is low dose, plus rivaroxaban twice daily. And this is 2A recommendation. Vitamin K antagonist with an INR of 2 to 3 is 2B, and single antiplatelet therapy, again 2B recommendation. So here you can see if you have low risk of bleeding, you use the recommendation, which is the same like the endo part. Well, if you have a high risk, then use single antiplatelet therapy, and this is variable. Again, it depends on your clinical judgment. How is the high risk? How you assess the high risk? And it's important to know the OAC score, which divide the risk into 4 categories. Now, very important to read what is in red, because this is, I think, the medical legal part. Do not add clopidogrel to aspirin and rivaroxaban dose more than 30 days. This is level of evidence C, but this is not to do. Again, patient with pre-existing indication of full dose anticoagulation or more than their month additional single antiplatelet therapy in an exceptional cases. This is very important to avoid, because I have seen a lot of bleeding risk complication not following these rules. And again, we don't have in peripheral triple antiplatelet therapy at all. It's not used at all. Well, I hope this second part give you a quick summary. I would just remember the definition of high risk in lower extremity arterial disease. This is the definition of high risk that they relied on it. There is a risk assessment, which we said. Now, this is what is the definition of a high risk. Well, high risk is any patient who have one of these elements. If you have chronic kidney disease, if he's diabetic, heart failure, if he has a chronic limb-threatening ischemia, if he presented acute on top of chronic, previous lower limb amputation, if he presented any of this, then he is considered the high risk. So this is the definition of high risk that is only to be applied in lower extremity arterial disease. This is not the high risk in carotid. This is not the high risk in vertebral. This is not the high risk in coronary. But this is the high risk when we speak about lower limb arterial disease. This is the high risk definition, which is it was taken same as in Compass and Voyager trial. So I hope with this quick summary of the second part to make the guideline easy, palatable, easily manageable, because we are going to use the ESVS 2023 guidelines over the next couple of years, not going to change. And it's a very nice document really to memorize. I wish you all the best and see you with the third and final part of the guidelines.